Hello, everyone. I'd like to thank Kathy and Tracy and Aaron for inviting me to participate in this session at the meeting. Regrettably, I'm out of town. I live in Phoenix. I can't be there in person, but so glad I get to talk with you a little bit today. Just to start, this is a difficult topic, and there's no way around talking about death that isn't difficult. So please just know that and be prepared for that. And I'd also like to offer my condolences to anyone in the room who's lost a loved one to epilepsy from any cause. The topic for today is talking about SUDEP and mortality in the Lennox-Gastaut syndrome. My job is to set the stage for that and give you some of the basics about the topic. And I will try and do that very briefly in 15 minutes and just emphasize the high points. In terms of disclosures, I have no financial conflicts of interest or really any other conflicts of interest, but just to note that I've been part of the Partners Against Mortality in Epilepsy, PAMI, for over a decade, and we'll mention that at the end. So in our brief time together, I'd like to cover a number of topics. The first one is premature mortality in epilepsy. The second is causes of premature mortality, and just to emphasize that although sudden unexpected death in epilepsy, SUDEP will be our emphasis, there are other causes which need to be considered. We'll talk about premature mortality in children with epilepsy in general, and then focus on what we know about premature mortality in the Lennox-Gastaut syndrome. And finally, ending it with a brief statement about prevention. So to get us started, this was a study published recently by the International League Against Epilepsy, looking at premature mortality in high-income countries. And the studies indicate that's roughly 2 to 8 times more common than in the general population with all comers. And these are largely incidence and prevalence studies, but not entirely. So that's a background. Something that came out of this study, I believe is worth mentioning. The first, as you can see on your left, is that the highest rates of premature mortality are in the young, which here I'm just arbitrarily defining as less than 40. But you can see a whole number of instances less than 10 years of age. So a disorder of the young and the older. The other eye-opener, at least for me, was that the highest rates occurred within 5 years after diagnosis. And so the practical implication of this is to recognize that when a diagnosis of epilepsy is made, the possibility of premature mortality needs to be discussed immediately. In terms of the causes of epilepsy-related deaths, this is a table published by Dr. Orrin Devinsky, who's been a major contributor to this field in 2015. Dr. Devinsky divides the causes between deaths directly due to epilepsy, deaths due to acute symptomatic seizures, deaths indirectly due to epilepsy, and deaths due to underlying neurologic disorder. So that's sort of the universe of possible causes of premature mortality in epilepsy. A number of years ago, some of the folks that are at this meeting, as a matter of fact, put together this manuscript. So this is causes of death in children with epilepsy, all deaths from 4 different series on the topic. And what you see here, these big black bars, these are non-epilepsy related deaths, which was a big surprise to me. And over here in the white bars, you see the epilepsy-related deaths. Let's look at the non-epilepsy-related deaths first. Show the greatest number. And what we see here in 3 of the studies is that pneumonia is the #1 cause by far of all the other potential etiologies. Obviously, this is extremely important because pneumonia, in theory, is preventable. When we looked at the causes of epilepsy-related deaths, sudden unexpected death in epilepsy was the #1 cause in all 4 series. And I think this is a surprise to many of us, particularly a decade ago, because I think we probably would have said, gee, status epilepticus, that would be the most common cause of death, or aspiration pneumonia. And we would have been right with aspiration, but these are epilepsy-related deaths. So what is this thing we call SUDEP? And the first bullet is the definition offered by doctors Lena Nashef and John Anagers in 1997. A sudden, unexpected, non-traumatic death in a person with epilepsy without post-mortem autopsy evidence of structural or toxicological, like drug-induced, cause of death, and was divided into definite, probable, and possible. In 2012, Dr. Nashef and colleagues expanded the definition, mainly to do research, to be more specific, and to include, was there a seizure witnessed or not, including suffocation, because as we'll learn, many of these deaths occur at night. People are found face down in the pillow, and previously it was diagnosed as suffocation. It was due to a seizure in many cases. Also, dry drowning, meaning folks that drown in the ocean or pool or bathtub, but there's no water in their lungs. So it wasn't the impairment of breathing due to water in the lungs, it was a seizure. Now, what about the incidence? The number of occurrences per year in the population. I'm emphasizing children equals adults for the following reason. When the American Academy of Neurology guideline was published in 2017, the data at that time indicated that that SUDEP was more common in adults than children. And the recommendation, unfortunately, followed that as well in terms of discussion. Within several months, Dr. Svensson and Thompson from Sweden published a very powerful paper that indicated the incidence was essentially the same, followed a year later by Drs. Keller and from Dr. Donner's group in Canada with the same finding. So whether a child or an adult has epilepsy, there needs to be a discussion. Now, in terms of numbers, and this is now a decade old, it was estimated as an underestimate, roughly 6,000 deaths in the United States per year due to epilepsy. SUDEP, as you can see, was the #1, twice as great as the next one. So again, confirming that SUDEP is the most common epilepsy-related cause. What about impact? 6,000 people compared to other causes of death doesn't seem like a large number. However, when Dr. David Thurman said, let's analyze the data with annual years of potential life lost, SUDEP was second only to stroke among neurologic disorders, Alzheimer's, ALS, multiple sclerosis, Parkinson's, in annual years of potential life lost. That's because of the early onset. When it happens to a child or a teenager, there are many potential years of life lost. So this really is a significant public health issue. Now, what are the risk factors for SUDEP? Many have been proposed. And it's, again, a huge literature, which I'm not going to go into now. But there's the best evidence that the risk is highest for those that have generalized tonic-clonic seizures and that have a lack of supervision during sleep, where 70 to 80% of the SUDEP deaths occur. This very powerful paper was published in 2020, again from Sweden. And what it showed was the risk is increased of dying from SUDEP by 27 times there's generalized tonic-clonic seizures in the year preceding. If the generalized tonic-clonic seizures occur during sleep, 15 times the risk. And if you don't have someone in the bedroom with you and one has tonic-clonic seizures, the risk is 67 times greater. So again, this immediately points us to potential prevention. Now we get to the issue of the occurrence and causes of Lennox-Gastaut, premature mortality in Lennox-Gastaut syndrome. So now we're focusing what we know about LGS. The occurrence is really the epidemiology, which formally is divided into prevalence and incidence, but you can only do that if you have some kind of population-based study. And the causes are what have been published that have caused these deaths. So is what is true in general true for LGS? This was an early paper in the literature from Dr. Ann Berg, 2004. And what it showed was that 13 individuals died, 2 related to seizures. And in this larger group, epileptic encephalopathy was almost 11%. LGS wasn't called out specifically, but when one reads the paper, LGS is included in this group. 2007, from the Camfields in Nova Scotia, population-based sample. And what I want you to focus down here is that 25% of individuals with LGS as the initial diagnosis died. So 25% of the population. And that's a huge increased risk. In Finland, there was a unique, one-of-a-kind study with a 40-year follow-up, 40 years of 60 deaths. Of those patients, 4 had LGS. This is one of the very few papers in which the cause of death was noted. And of the 4, 3 were due to SUDEP, 1 was respiratory failure, as we learned from the more general population. More recently, 2018, a study from the Mayo Clinic in Rochester. And this looked at late onset, meaning Lennox-Gastaut syndrome that presented after 10 years of age. And I think we'd all agree that maybe this is a different kind of entity, but it met criteria. And of those 10 individuals, 1 died due to SUDEP. So 10%. Again, 10%, 25% significant risk. This is a review of the literature from Dr. Donner's group. And what they found were 5 individuals that had been reported with LGS. And this points out something that I think is very important when looking at the literature. The numbers that you get depend directly on how a search was performed. And so we know that there were more than 5 instances, but they just weren't found by the criteria of this systematic review. So I think we'd all agree an underestimate. This is from the North American SUDEP registry. Again, these are uh, individuals who have passed away and their loved ones have contacted the registry and said, we'd like you to have the data and study them. In this cohort, 3% were Lennox-Gastaut syndrome, five different individuals than in the previous publication. And again, all SUDEPs, because this was a SUDEP registry. Now, in 2024, Dr. Joseph Sullivan, who's a significant investigator, as you probably know, in the world of LGS, did another systematic literature review, global epidemiology, Dravet syndrome and Lennox-Gastaut, prevalence, incidence, diagnosis, and mortality. So again, a very, very well done kind of study. And what did he find? 67 articles, Dravet only, LGS 17, both were 7. And what this points to is that although my sense was that there are far more people with LGS, Dravet has had more written about it, largely because it's a single gene mutation, whereas LGS is a heterogeneous group. But this has real implications. In the group of LGS, no SUDEP occurrences were reported. The mortality was 6 per 100,000 patient years for LGS versus double that for Dravet syndrome. He stated only 4 articles provided mortality information for LGS, none of which reported SUDEP data. The cause of death was unrelated to SUDEP, was reported for 1 individual with LGS in 1 study. So again, this points out how little we really know about LGS as recently as this year. And this is just the table from that study. And that 1 instance where it was reported, it was aspiration pneumonia. Again, fitting with what we knew from previous work. And so how do we prevent mortality, premature mortality? First thing, early diagnosis and treatment of pneumonia. And I can't say that strong enough because pneumonia is a very, very common cause of premature mortality and in theory can be prevented in many instances. The second is to identify etiology. And we live in an age of gene testing. There are more specific therapies available all the time and more anti-seizure medicines approved all the time for LGS. Recently, which is great news, but a diagnosis has to be made, and the earlier, the better. We know from the literature that I've presented to you that generalized tonic-clonic seizures are far and away the biggest risk factor for SUDEP. So we have to be aggressive with therapies. What's the evidence that some things work? And as you can see here, medication, surgery, and vagus nerve stimulation all have some evidence, which I think is pretty hard stuff. The VNS is a little less sure, but certainly on the map. So these things can prevent SUDEP. Nocturnal supervision. We know from that literature that was discussed that if someone's in the room, the risk of dying during a seizure is significantly less. Now, seizure warning devices, there is no hard evidence that these prevent SUDEP. However, there's very good evidence that they signal someone, like a parent or a bed partner, that something is going on. So I certainly understand the logical connection between knowing about it and doing something about it, equivalent to nocturnal supervision. And finally, just to mention, I'm involved in an epilepsy learning healthcare system where we try and make these diagnoses and learning about them as a network as soon as possible. All of the interventions require discussion with the patient and or the caregiver. That is the sine qua non of prevention. There must be a discussion, and obviously you can guess that I believe, and parents request, this be done as soon as possible. So what are the key takeaways that I'd like to leave you with? The first is that premature mortality is a real thing in people living with epilepsy, and regrettably, not all providers recognize this. The frequency of premature mortality is related to the severity of the disorder, and we're talking generalized tonic-clonic seizures. So something needs to be done. SUDEP is the most common cause of epilepsy-related causes of premature mortality. But please don't forget the other etiologies, especially pneumonia, preventable. And I have to say that in getting this presentation together, I was stunned by how little is known about premature mortality in the Lennox-Gastaut syndrome, indicating that much more research is needed. And to hammer it home again, discussion as soon as possible with the patient and caregiver is essential for ethical and direct care. I want to put a plug in for the organization Partners Against Mortality in Epilepsy that has a website, as you see it here, and I'm involved with that with Gardner Lapham and Tom Stanton and others. And our desire is to provide as much education and bring people together who've suffered premature mortality in epilepsy as possible. Our meeting at the AES is on December 5th, and you're all very, very welcome to join. And with that, I will thank you for your attention. Again, apologizing for not being there with you in person to answer questions. But if I can provide any more information, here's my email address. Please feel free to contact me. Thanks a lot.